Pulmonary. You need to go and understand most of those questions about asthma exacerbations, COPD and COPD exacerbation, pulmonary arterial hypertension, the WHO classification of the pulmonary hypertension, diagnosis of pulmonary hypertension, and treatment. Uh, Asthma, you have many questions about what's the next step for treatment and the stepwise for the use of inhaled corticosteroids, SABA, and LABA, and later on LABA. Most of the time, the question about the add on to the inhalers and inhaled corticosteroids, either low dose or high dose or intermediate dose of inhaled corticosteroids. There are some questions about the use of systemic steroid in case of severe asthma. As a patient that on discharge, you need to discharge them with a short course of systemic steroid to decrease the recurrence of the disease. And there are some questions about the indication for intubation. If the patient has severe asthma attack and the APGs looks like respiratory acidosis and PCO2 is normal or mildly elevated, then that's or high, that means this patient is looks very tired and he is now pending respiratory failure because you are expecting to see respiratory alkalosis. Questions about exercise-induced asthma, the treatment will be short-acting SABA. Persistent cough or persistent asthma and persistent COPD, you need to know what's your differential diagnosis here. If the patient has a COPD and you started the treatment for the acute COPD exacerbation, antibiotic, short course steroid, but the patient is not improving after 24 to 48 hours of reevaluation, you have to rule out the differential diagnosis. Here will be very likely maybe patients encountered another infection like a pneumonia, and you have to treat him for pneumonia, not for COPD exacerbation. And the antibiotic course and dose and duration will be different. Maybe the patient developed a heart failure, either he has already a reason to cause a heart failure, an ischemia, the stress, the volume overload, the fluid, the right-sided heart failure, and resulting in severe decompensated heart failure. So you need to treat the underlying heart failure or due to arrhythmia-induced heart failure, which is in the COPD patients. You need to expect and be familiar, especially on the test for multi-atrial tachycardia, and you need to control this arrhythmia. PE, patients with a COPD already a high risk for pulmonary impulse, and you need to, if your patient is not improving and the saturation is low and tachycardic, you need to think and consider PE as one of the differential diagnosis. In asthma, it's a little different with the patient with persistent or recurrent attacks of asthma in a short period with no improvement. It's good to think about some differential diagnoses like aspergillosis or Church-Strauss disease. And Church-Strauss is a systemic disease, systemic vasculitis associated with mono or polyneuropathy, uncontrolled asthma, paranasal or sinus abnormalities, eosinophilia. And the last one is maybe all again an infection, and the patient encountered pneumonia. So you need to rule out infection as a cause of persistent asthma. In general and simple rule for treatment of acute COPD exacerbation, know why and when to use systemic steroids, know the inhalers, the indication for the antibiotic, and how to classify your patient. In general, if you classified your patient as a mild COPD exacerbation, you don't need the antibiotic and you don't need the systemic steroid. If you classify him as a severe COPD exacerbation, that's a patient is abnormal vital signs, ABGs looks with severe acidosis. That means this patient may be required a non-invasive ventilation and possible ICU admission. Very likely, this patient will require IV antibiotics and IV steroids or systemic steroids. Um, in between is moderate, so depends case by case, and if there is any indication for the antibiotic or the steroids, you add them. In asthma, acute exacerbation, uh, add scheduled as well as PRN inhalers. Uh, and those inhalers needs to be continued for 2 to 4 weeks after acute exacerbation. You may have one of those questions for how long you're going to continue the step up or the high level of add on breathing treatment. for 2 to 4 weeks. Then you go back to the baseline. Short course of steroid, yes, asthma will need a short course of steroid 5 to 7 days after discharge, not like COPD. On the discharge, usually you don't need to give them steroids. Uh, know the differential diagnosis of asthma mimic cough. Patients had a cough. What kind of cough is this? Cough is more nocturnal. This is more likely to be asthma. Asthma has they have more cough at night and wheezes at night. And once they wake up, they continue to have the cough and the wheezes. Not like obstructive sleep apnea and or GERD, gastroesophageal reflux. They may have some regurgitation, heartburn that is improving with PPI, or they improved when they sit up in erect position. Uh, Upper respiratory tract syndrome associated with the urinary runny nose and night cough, treat them with inhaled steroids. Pulmonary function test is important to read the pulmonary function test. Just know that in a COPD it's not fully reversible, but in asthma it has to be full or near complete resolution with the inhalers. There is in between COPD asthma overlap when there is a reversibility of forced expiratory volume per second FEV1 more than 12% and total lung capacity more than 200 cc. The differential diagnosis for massive hemoptysis, you may have one of those questions where the patient has severe hemoptysis and drop in hemoglobin. Your first differential diagnosis is aspergillomas, then bronchiectasis, necrotizing pneumonia, and it's less likely to be malignancy. Scleroderma and association, either the systemic scleroderma or limited scleroderma, and associated with interstitial lung disease and pulmonary hypertension. In the systemic one, there is highly association with pulmonary hypertension. Asthma step up treatment in general, you start with SABA, then you give SABA with inhaled corticosteroids or LABA with inhaled corticosteroid, then you add LABA with inhaled corticosteroid intermediate dose with SABA PRN. Then later on you can add leukotrienes, antagonist, mast cell stabilizer to those treatment, especially in mast cell stabilizers and leukotrienes inhibitors or antagonists if the patient has eosinophilia. COPD step up. You need to be aware with the new guidelines, and before we used to classify them according to the pulmonary function test and FEV1 to the severity. Then you go to the gold classification, and depends on gold classification, you go with the treatment that was class A, B, C, and D. Now we have class A, B, and E. There is no more C and D. They put them in one category, and in class A, you start either with SABA or SAMA. Then in the class B, you put LABA or LAMA with PRN. SABA SAMA means long acting more, especially the LAMA, the muscarinic ones. And for class E, it's LABA and LAMA plus inhaled corticosteroids, PRN, SABA or SAMA, with uh, maybe inhaled corticosteroid if indicated, and the use of azithromycin and roflumilast, especially those patients with recurrent admissions, hospitalization. If they are former smokers, azithromycin more favored than roflumilast. Uh, you will have at least one question about class E. Palliative treatment for COPD, one of the questions will be there about when to send the patient for palliative treatment, when to consider oxygen only as a palliative treatment, theophylline, rehab, pain control, anxiolytic, facial cooling and fans, opioid. Every patient after acute exacerbation and the indication for acute rehab or respiratory rehab. Long-term benefits, you may have those questions about long-term mortality and morbidity benefits in COPD. It's usually oxygen and the indication for oxygen either by PO2 less than 55 or saturation less than 88. Uh, but if the patient has a core pulmonary, your threshold will be lower, so PO2 will be 59 and saturation at 89, and you start giving them oxygen at home. There is a question about reactive airway disease or reactive occupational disease. The patient will have asthma-like symptoms that happens only during work or within 24 hours of work. Uh, Diagnosis by methylcholine stimulation test, same as asthma. And usually those patients are respond very poorly for asthma regimens, the SABA and SAMA and HELP. But the treatment is more inhaled corticosteroids and avoid exposure if possible. And this kind of reactive airway disease will improve and resolve by itself within 2 years. There is a question about acute bronchitis or post-viral bronchitis when the patient has some kind of viral infection, symptoms and signs of upper respiratory tract infection, but there is no systemic symptoms or symptoms of pneumonia, followed with persistent cough for weeks. The treatment is bronchodilators. You don't need to do any workup for those patients if they come back to the hospital or they come back to the clinic. You don't need to do any chest x-rays just because they have a persistent cough. All they need is a bronchodilator because this is an inflammatory response. Again, this is the classification of the new gold classification 2023 with the A, B, and E. It's the same for FEV1 for the grading, and then it's the same here for the exacerbation, either two attacks or one attack. You go A and B, then grade E, and that depends on how you're going to treat them. If you are, they have just treatment outpatient for dyspnea and the treatment for the acute exacerbation and adding GLABA, LAMA, azithromycin, or roflumilast. There is a question about the loop and the pulmonary function test again, especially with the patients with vocal cord paralysis when there is an inspiratory phase plateau. Here you'll see it. So if you suspected asthma or COPD, first thing you need to do to diagnose them is a spirometry to confirm the diagnosis. Inhaled corticoids, because we're going to use that for asthma and will be frequently used there. You need to understand the side effects as an oral candidiasis, dysphonia, and skin bruises. Vocal cord dysfunction, one of those things you need to know, as a patient may come with choking sensation, throat tightness, dysphonia. So asthma doesn't cause those symptoms. The patient should not have a dysphonia, should not have an inspiratory wheezes. When the patient has this, then if you do a pulmonary function test with loop, you're gonna see flattening in the bottom here, flattening. And if you do a laryngoscope, you're gonna see the adducted cords. And the treatment will be kind of speech therapy. Avoid the triggers. Usually those are triggered by stress. If the patient in severe stress and respiratory failure or pending respiratory failure in the ED, you can use non-invasive ventilation with a PEEP, high pressure, positive airway pressure, or CPAP, or you can use mixed helium oxygen. You can also ask them to sniff in a bag. The other side effects of inhaled corticosteroids or other problems with patients with asthma is aspergillosis or allergic bronchopulmonary aspergillosis. The patient will come back or recurrent attack of asthma, chest infiltration that is fleeting, sometimes on the right side, then on the left side. They may have eosinophilia, they may have hemoptysis, brownish mucus because it has some blood. They may have in their periphery eosinophilia, elevated eosinophil in the blood. You can do to diagnose them either skin prick test uh, or you check for IgE level, which will be elevated, or serum antibodies with aspergillosis specific antibodies. Then you will have your diagnosis, and you don't. If you do this, the skin test or the IgE level with specific antibodies for aspergillosis, you don't need to do the bronchoscopy and lavage. That's enough for the diagnosis, the antibodies and the IgE level. Treatment usually both steroid and itraconazole or antifungus. There is a questions about pulmonary nodule and what to do for those nodules. If the nodule less than zero point 0.6 centimeters, then just follow up after 2 to 3 years with those CAT scan. But if the patient has more than zero point 0.8 centimeters, then those need to be biopsied and confirmatory test with a biopsy and pathology. In between, it depends of the patient's high risk or low risk, phase high risk, smoker, old age, exposure to carcinogen, then you need to do the biopsy. There is a questions about mechanical ventilators. um, as one of the example, if the patient was on a ventilator and you are planning to extubate him but he's still on the ventilator, has this signs of agitation, grimacing, trenching with his teeth, what called fighting the ventilator, you must improve his pain killers and give him more of analgesics before just sedating him, and use the morphine or muscle relaxants, or using any of sedation rather than pain control to improve his pain. That will improve his respiratory stress. Benign asbestosis, you're going to see some pleural fluid that high in eosinophil, more than 10%, and thick pleural wall with history of exposure. A patient with shock, with low blood pressure and no access for IV, or difficult to place an access in as emergency, you can use intraosseous, not intratracheal, and not placing a central line. They will have this options also on the test. Go for intraosseous. A patient with anaphylaxis, first thing to do is an IM epi. Uh, Maybe the clinical picture with the patient starting to have skin rash, GI upset, nausea, vomiting, respiratory wheezes, and the blood pressure start to drop. And first thing to do is to give him the IM epinephrine. Don't wait till he crash, and it will be very late. You may have this young patient, especially younger than 45 years old, with a new onset COPD, and a chest X-ray or a CT scan looks like COPD or pulmonary function test. It's a COPD, but he's young or never been exposed to smoking, or there is a minimal exposure to smoking. Uh, Also may be associated with unexplained liver disease, or skin recurrent skin infections, subcutaneous and adipose tissue infections like paniculitis. Then you have to suspect alpha 1 antitrypsin deficiency. Know the treatment of alpha 1 antitrypsin replacement or augmentation therapy with the pooled human alpha antitrypsin. The indication usually a young age, persistent, severe disease with pulmonary with FEV1 from 30 to 60 of a predicted value. Genome, at least two genes are positive, so then you need to treat them with alpha antitrypsin. There is a questions about provoked and provoked DVT and when to stop the anticoagulant. If it's provoked DVT and no more persistent provoking factors and the patient is not a high risk, then you can stop the anticoagulants within 3 months. If it's unprovoked DVT and the patient is a high risk, or hemophilia, or thrombophilia, or D-dimer persistence high after 4 weeks, then it's better to keep him on or to keep the patients on anticoagulant. When to test for thrombophilia, this is another question. If it's the first attack and the patient is high risk, like family history is positive, young, then you can test them. Also, you can test if it's recurrent, especially recurrent or massive PE, or unusual site, or arterial thrombosis. Then it's better to start and investigating thrombophilia. Uh, Adult cystic fibrosis, you're gonna see some adults that diagnosed with cystic fibrosis. It's milder form than children or pediatric cystic fibrosis. They have less pseudomonal infection, but they have more atypical infection of Mycobacterium avium. They have more allergic bronchopulmonary aspergillosis. Usually, the clinical picture comes with recurrent chronic respiratory infection, more affecting the upper loop with bronchiectasis. They male, they may have absent vast difference with infertility. They may have pancreatitis. Again, treatment or screening for the diagnosis, you need a sweat test, then DNA analysis with a two gene mutations, or a nasal potential differential test. That's how you diagnose them. They may have a CT scan with a tram track appearance, tree and bud appearance, and that's the diagnosis of bronchiectasis. If you have a patient with a COPD, moderate to severe, class either B, C, or D, or as we said, E now, they may ask you about when to send them for rehab. The indication of FEV1 less than 50 after each acute exacerbation. So you grade them. Doesn't matter the classification is B or E. It has to be again not usually in A but B and E, and at the same time FEV1 less than 50. Then you have to recommend for them acute rehab. uh, Inflammatory idiopathic pulmonary fibrosis, an elderly patient with the reticulonodular pattern, especially in the bases of the lung, recurrent shortness of breath, dyspnea, cough, dry cough, usually, and CT scan will be very diagnostic. Usually, you don't need a biopsy, and they may not ask you about treatment or the imaging needs, but usually it's a diagnosis test. Sarcoidosis is common on the test, either about to diagnose this patient or to start a treatment. One of the examples there is Lofgren syndrome, means the patient has the skin lesion, the joint pain, ankle, or large joint pain, erythema nodosum, tender nodule in the legs. Treatment usually requires NSAIDs, but maybe a low dose of glucocorticoids, colchicine, or hydrochloroquine. And in these scenarios, you don't need to do a biopsy. They may have a patient, but maybe they will ask you to do the chest X-ray to see the hilar lymphadenopathy. Sarcoidosis with a clinical picture and radiologically finding. Maybe you don't need to do histopathology, but if you have the histopathology from a mediastinal approach, or the only way to have a mass or a biopsy, the best way is to go through the ABU, which is endobronchial ultrasound, and that will be the best access for diagnosis a mediastinal lymph node. Again, a patient with a chest X-ray showed lymphadenopathy and skin lesion. That's sarcoid. You don't need the biopsy. They may ask you about oxygen on the flight. Oxygen on flight, you have to ask two questions. If the patient already on oxygen, then just increase the oxygen 1 to 2 liters at the flight. If the patient's not on oxygen, you need to ask if the patient requiring oxygen on exertion or at rest. If a patient saturation at rest less more than 95, then no need for oxygen. And if the patient at rest saturations less than 92, then yes, he will need oxygen. So at rest, already the patient required oxygen and saturation less than 92. When he goes to the flight, his oxygen will drop 1 to 2 at least, or 3% down. That means in 89, 88, that means yes, he needs oxygen, so you give them oxygen. In between 92 to 95% saturation of oxygen at rest, those patients you need to classify them if they are high rest or low rest. They high rest means have pulmonary hypertension, they have severe structural lung disease, already FEV1 is less than 50%, then yes, those patients will require oxygen on the flight. There is a question about fat embolus, either a diagnosis or treatment. A patient after long bone surgery within 24 to 72 hours start to have dyspnea, respiratory distress, altered mental status, confused, skin rash. They may not have all those symptoms, maybe just altered mental status, but they want you to suspect fat embolus. Treatment is fix that bone, and respiratory support may require ventilation. ARDS and mechanical ventilator will do in the next video.